We have come to the last talk, which I'm going to talk about the brolucizumab and the vasculitis and the occlusive vasculitis per se as a specific phenomena which we have never seen. We would try to understand this phenomena a little bit more in detail. I think we have sufficient time. I might take a little bit more than 10 minutes here because rather than just talking about the brolucizumab and vasculitis, I would just try to talk about a little bit in the background, because we have been covering this molecule and trying to understand this molecule since last 2 years. So it is kind of a story for us actually, that how and it's a wonderful story. There's a lot of learning as far as this molecule, the way the processes are done and the way the rebuttal. So a lot of learning from this story. So again, this is our contribution in the form of publications. And again, the same group I would like to highlight. All of them, and especially a lot of hard work went through these two of the DNB residents. Am I audible? My connection says unstable.
Yes, Doctor, you're audible. Yeah.
Okay. Thank you. So these are my financial disclosures, and so brolucizumab, when even launched, when we saw the brolucizumab, what kind of molecule it is, it was a structural revolution. We were all in initial phases of a study, and that was the time we were excited, and this was the first paper that we published, that brolucizumab is kind of a leading an era of a structural revolution for long-term VEGF suppression. And why it was a structural revolution, I would say, because it was the smallest molecule, not only in the ophthalmology, but it was the smallest molecule what exactly, it compares with what we have in our armamentarium at this point, what we use at this point. If you look at the bevacizumab is our microbiology and MBBS, that you have a FC portion, you have FAB arm, and that's where it's, kind of a big size molecule with a light and the heavy chain. Similarly, if you look at the aflibercept, although it had a decoy receptor, I'm not going into the detail of that, but what I'm trying to highlight here is it also had FC portion. The importance of FC portion is that it provides any kind of molecule. But if you look at ranibizumab was kind of a cutoff from the FAB part, and it was lacking FC portion. FC portion had some immunogenic responses also, but overall stability is the main function of FC portion. And if you look at brolucizumab is further small. Now the question arises, such a tiny molecule without having FC portion, how can it be stable? So to stabilize it, it had a kind of a nice chain, a protein chain, which was stabilizing it. Now, next question that somebody should ask is, that's what we asked, that what structural revolution other way around to do some adverse events also, but science has to evolve. So what structural evolution and a small molecule could achieve was better penetration in the retinal layers, easily understandable because smaller molecule it can retinal layers, which was proven in the baseline studies of brolucizumab that it was 2.2 times more diffusible if you compare with the Lucentis. And on the other hand, it's, you can understand easily that more molecules you can pack in a similar dose. So actually you can pack 20 molecule, it can have a faster exit from the systemic circulation. So chances of even systemic adverse events could be less. But this was all, when the structure was being designed and That's where we published these couple of papers. Because of the smaller structures with the packed doses, it could have an extended suppression. And again, we published another paper that is just an anti-VEGF or beyond, because it was, it was kind of different from the other anti-VEGF in terms of the penetration deep into the retina. And so our excitement continued, and as soon as we saw that Hawk and Harrier results are announced, and it showed it had a greater efficacy and equal safety. But we had few questions in terms of the design of the study when it was the way with the aflibercept. So because aflibercept was tested 12 weekly, however, brolucizumab was allowed to switch between. And even another aspect was that while from CFT to BCV after 16 weeks, but nonetheless were answered very well by Dr. Praveen Dugal, who was heading the trial. After this, we to simplify this information for physicians, we had published these couple of papers. So what are the key learnings from Hawk and Harrier, and what is the kind of impact on fluid that brolucizumab had. And the day came on October 8, 2019, when Novartis received FDA approval from the in the form of BV. Is approved as patient next because of some kind of pricing structure. Then after that, few months, on 23rd Feb 2020, ASR vasculitis were reported, and out of those 14 cases of vasculitis, 11 were occlusive, which was never seen with any other anti-VEGF drugs in the past. So that was kind of alerting, because it lost their eyes. So it was kind of vision-threatening inflammatory eye condition. Novartis immediately took a step. We should thank Novartis for that, and they formed external SRC. What SRC had, because the drug had only 3 months or 4 months after the SRC, what it could do was it could again call back the cases who were reported as an IOI from the Hawk and Harrier studies, and then they tried to again assess those cases. And when SRC submitted their report in June 2020, what they found was incidence of IOI was quite similar to what was seen in the trial, but retinal vasculitis, retinal vascular occlusion was much higher than what was seen in the trial. Incidence of retinal vasculitis was 3.3%, and retinal vascular occlusion was 2.1%. So then Novartis updated. So if you look at the label, which was there in 2019, you would not find any mention of retinal vasculitis and retinal vascular occlusion. However, if you look at the June 2020, on the warning of the label, it was included. So clear disconnect from the real world. And at the same time, we were getting some data from abicipar also. So, we highlighted this drug, that there is kind of disconnect from the real world and the trial. And now, just for the information, although Raja has shown some of the cases, but means again, I'll go back to the same paper by our good friend Carol as a occlusion or a vasculitis phenomena. If you look at the picture A is a pre-brolucizumab injection, and the OCT, if you see, a lot of fluid, subretinal fluid is there. In C, if you look at, there's a whitening, but if you look at, the impact on fluid is quite dramatic. Even this ischemia developed, but drug was working. And in the E, if you look at the E, it is a optos picture, so you cannot see much details, but still you can see on the yellow arrow, the kind of phlebitic sign, and it is very well visible in all and the ischemia. Again, another picture, you can see very clearly visible a lot of occlusions at multiple levels. And this was a patient, who was given bilateral brolucizumab. Initial stage, if you look at that, there are tiny hemorrhages of vasculitis and on the periphery, but after some time, both the eyes, they went into the hemorrhagic vasculitis. And am I audible?
Yes, sir.
Yes, Ashish.
Okay, and this was the kind of presentation with the IOI with the retinal vasculitis. You can see with white arrows, multiple all across. Again, here, if you see, there's a yellow arrow where you can see the vascular thickening, and on the nasal side, the sclerosis on FFA shows staining and the ischemia. So now, after seeing all this, after that, voice of a retinal legend, Dr. Phil Rosenfeld, I was fortunate to be a part of his training institute at one point of time. He wrote an editorial in American Journal of Ophthalmology with a title that is this a 737 max moment. So what exactly he meant by 737 max moment, I'm not sure if everybody is aware about this. Just for the people who are not aware about this, 737 MAX was a plane which was, a kind of a superior design of 737, and in terms of its capacity in various aspects. So, but as soon as it started flying, initial 2 flight crashed and it killed 346 passengers. And then the 737 MAX plane was grounded for 2 years and it started flying back again in October 2020. So that's how the brolucizumab was compared, and what he recommended. I love this slide. I love this interaction. If you look at the interaction between, Dr. Phil Rosenfeld and Dr. Dirk Saur, if some residents are listening my talk, I would request them to go and read about inspirational personality. He is a person who was a man. He's the person who has designed brolucizumab. So in the editorial, what Rosenfeld wrote was that can fly again? Can we have a temporary moratorium on this drug? But then Dirk Saur replied that, it's the physician's choice, because, he felt that the drug still has important role to be fit in the practice of retina. But again, because Dr. Rosenfeld, he was not convinced, and look at his statement at the end, that how many more patients need to lose vision before the moratorium is implemented on brolucizumab. So it means this is a learning, how you communicate, how the industry leader communicate, and how as a physician, we should really be toward the safety of our patients. Still, what happened? 60 countries as of now for the management of neovascular AMD. And after this event, then we had this editorial in British Journal of Ophthalmology for brolucizumab. We highlighted a few points that how, things in terms of the safety, how we can have better safety measures for the patients. And that was the time when, am I audible? Am I audible?
Yes,
You're audible.
Okay. So then that was the time in February 2020 when the approval was given by the DGCI in India. And I know my country, sometimes what happens, people and the physicians, retinal physicians, are not aware what is happening in the background. Sometimes, because they are busy in clinics. So I wanted to bring this information and wanted to take help before we offer this drug to our patients in India. So we organized a global symposium on brolucizumab in February 2020, exactly the same time when it was launched in India, with the help of leading experts who had, especially most of them were from the United States, Dr. Thomas Albini from Baskin Palmer, Dr. Kwan from Stanford, so and Dr. Vaishali from here, so that to understand, and Dr. Cooperman, my mentor, to understand that how to go about it in India. Discussion and the symposium outcome came in the form of a mitigation plan. Now, there was a mitigation plan proposed by Caroline, and what Caroline did was, if in case any patient develops vasculitis or IOI, how to manage those patients. That was the mitigation plan proposed by Caroline. But Caroline mitigation plan was not involving how to choose the patients and how you follow up those patients. And after this symposium, with the help of all these experts from entire globe, we have published a brave, safe recommendations right from the choosing patients, how you choose the patient, and if some patient develops inflammation, how to manage them. And that was the time when nobody had the real world data. Although, I never used even a single brolucizumab till now, even that time also, but I wanted to bring the real world data to see, what is happening. So then we try to collaborate with all the people in the United States, all the clinicians in the United States who were using this drug. And we brought this publication, first real world data study, BREW study. And what we found was it was very efficacious drug. As you must have seen in all my slides of the Caroline paper, where even the vasculitis was there, but drug was fantastically efficacious. And in our study, we could not find any adverse event, but I would not take it that because it was a too small data, and to find out an adverse event which is too small in percentage, you need to have a real big sample size, which we didn't have. So our power to detect adverse event was not enough in this study. So retinal vasculitis and retinal vascular occlusion, it was and it is a mystery for us and for the industry also. So what we propose, because further less, so other than brolucizumab, we were simultaneously working on the biosimilar. So biosimilar is kind of, we published some of the data when to understand the biosimilar leading to some of the immunogenic phenomena in the beginning. So it is kind of, we had some of the old stacks of wine papers, old stack of papers. So when sometimes, old wine gives you some information that is more tasty. So we turned back the clock. We went back to our papers, which we published in terms of to understand the biosimilars. So what we published in 2019, even when the brolucizumab.
I'm sorry to interrupt Dr. Ashish Sharma, but I guess we are running short of time, and there are a few more doctors.
We have 20 minutes of discussion, so we can cut short that one.
Yes, but there are some two doctors who have just texted you in the chat that they have to leave in 2 minutes.
Yeah, no, actually, I have to go for other session. So can you?
Okay, I will conclude that as quickly as possible.
Okay.
Thank you so much.
Yes, thank you. So, so basically, we had, we proposed type 3 reaction. We to Dr. Dirk Shore, and he accepted that yes, pre-injection ADAs were high, and we were opposed by the group from Thomas Albini because they had a vitreous biopsy and they put forth the type 4 reaction because they found those cells in which favor the type 4 reaction. But again, in this editorial, we re-emphasized our stand as the type 3 reaction and the lack of, and we feel that lack of vessel wall analysis, was there in the study by the Thomas Albini. And as Dr. Raja mentioned, recently news is that Merlin data is out and brolucizumab has inflammation approximately 9.3%, much higher, and they have completely stopped all the cases, and they are recommending that any case you should not inject brolucizumab less than 8 weeks. What we propose is bio better for brolucizumab. The is that BioBetter need to go through the entire trials again. So we are tracking this story. That's what we say. The story is not yet finished, and best is yet to come. And thank you for exceeding, and sorry for exceeding the time. Thank you all for joining us. And this is again a great teamwork with the help of my residents and other collaborators. Thank you so much.